Good day, colleagues. Today I am presenting the risk stratification in patients with endometrial cancer to plan the adjuvant treatment. The table of contents, we're going to go through the background, the prognostic factors, the evidence available, and the discussion and conclusion. The global cancer statistics state that the second most common cancer in females is endometrial carcinoma, and it is the fourth leading cause of death due to the gynecological cancer. It is estimated just over 382,000 of new cases and just over 89,000 deaths worldwide in 2018. The International Agency for Research on Cancer states that the estimated 50% increase in the incidence by the year 2040, and the 5-year survival rates are estimated at 80% in all stages. However, majority of these cases are diagnosed in early stages, that is stage 1 and 2, and the 5-year survival rate is estimated at 95%. 20% of these women unfortunately die from their disease, and mainly due to the aggressiveness of the tumors or advanced stages or both. Historically, the standard treatment of endometrial carcinoma is surgical staging, total hysterectomy, and the bilateral salpingo oophorectomy. The adjuvant treatment in endometrial carcinoma has been controversial in the past, and that was due to different systems of risk classification that have been used in the randomized control trials. However, these randomized control trials suggested increasing role of adjuvant treatment in the endometrial carcinoma. The recent studies have two areas of focus. The first one, there is an evaluation of new prognostic factors and definition of prognostic subgroups. And the second area of focus is the assessment of efficacy of adjuvant treatment in different prognostic subgroups. Prognostic factors are well known and published by the International Society of Gynecological Pathology, and these include the histological type, the tumor stage, the tumor grade, the depth of myometrial invasion, the lymphovascular space invasion, and the age, even though age was not published or mentioned by the International Society of Gynecological Pathology. Let's look at the evidence available currently. Let's start with the first trial, the POTEC-1, which is the post-operative radiation therapy in endometrial carcinoma. The objectives of this trial were to evaluate the local regional relapse, the overall survival, and toxicity. Then the inclusion criteria was high intermediate subgroup, which include stage 1A, grade 2 or 3, stage 1B, grade 1 or 2. And the participants were randomized into the external beam radiation versus no additional treatment, and the follow-up period was 15 years. And the results showed local regional recurrence of 5.8% in the external beam radiation versus 15.5% in no adjuvant treatment. However, the majority of the local regional recurrence in no adjuvant treatment were found to be vaginal, and 74% of participants had vaginal recurrence. The overall survival was not different between the two groups. In the multivariate analysis, risk factors were detected as age over 60 years and the grade 3 tumor. And in conclusion, the trial showed that the external beam radiation has no effect on overall survival in this high intermediate group. However, the external beam radiation reduces the local recurrence. The second trial is the GOG-99, and the objective of this trial was to evaluate the recurrence-free interval, the overall survival, and the toxicity. The inclusion criteria was the high intermediate subgroups with the following risk factors: grade 2 or 3 tumors, the lymphovascular space invasion, and the outer one-third myometrial invasion. The participants were stratified by age. Those who were 70 years or older were required to have one risk factor, and 50 years to 69 years of age, they were required to have two risk factors, and those who are younger than 50 years of age, they were required to have all of those three risk factors. And these participants were randomized into two groups. The treatment group were on the pelvic external beam radiation 50.4 grays in 28 fractions versus the control group, which received no adjuvant treatment. And these participants were followed with a median period of 69 months. And the results showed a 2-year cumulative incidence of recurrence of 26% in the control group versus 6% in the treatment group. The toxicity was statistically significant in the treatment group, as evidenced by the toxicity in the gastrointestinal tract, genitourinary, hematological, and cutaneous. And in conclusion, the adjuvant radiotherapy decreases the risk of recurrence in intermediate risk, but should be limited to the high intermediate risk definition. The next trial was PROTECT-2, vaginal brachytherapy versus pelvic external beam radiotherapy for patients with endometrial cancer of a high intermediate risk. This was an open label non-inferiority randomized trial. The objectives were the local regional relapse, the overall survival, the disease-free survival, toxicity, and quality of life. The inclusion criteria were high intermediate risk, which included Stage 1A grade 3 tumors, Stage 1B grade 1 or 2 tumors. The design was the external beam radiation of 46 gray in 32 fractions versus vaginal brachytherapy at 21 grays in 3 fractions or 30 grays in low dose rate. And the results showed that the local regional recurrence or relapse was 2.1% versus 5.1% in the vaginal brachytherapy. The 5-year overall survival and the 5-year disease-free survival, they were all similar. So there was no difference in these oncological outcomes. However, the gastrointestinal toxicity was found to be 12.6% in the vaginal brachytherapy versus 53.8% in the pelvic external beam radiation. And the conclusion of the trial was the vaginal brachytherapy is the treatment of choice for high intermediate risk group. The next trial, the POTEC-3, the Adjuvant Chemoradiotherapy versus radiotherapy alone for women with high-risk endometrial cancer. The objectives of this trial were to evaluate the overall survival and the failure-free survival. The inclusion criteria were the high-risk group, which were stage 1B, grade 3 or lymphovascular space invasion or both, the type 1 endometrial carcinomas of stage 2 to 3, and the type 2 endometrial carcinomas of stage 1 to 3, which included the clear cell or the serous histological type. The radiotherapy group received 48.6 gray into the 7 fractions, and if the cervix was involved, then they would receive the high dose rate of brachytherapy of 10 gray in 2 fractions. The chemoradiotherapy group received the same radiotherapy dose followed by 4 cycles of carbotaxol. And the results showed statistically significant in the overall survival in stage 3 tumors, the failure-free survival in stage 3 tumors. And in the serous cancers, the overall survival and the failure-free survival, those were significantly different. And it showed a favor at this stage 3 and with the overall survival in the serous histological types. And the conclusion was the chemoradiation is recommended for stage 3 high risk group, and the pelvic radiotherapy alone is optimal for stage 1 and 2. There was, however, an unknown benefit for serous histological type, and the suspicion was most likely the influence of the molecular profile. And the molecular profiles are a current attraction for the etiology and the prognostification of the endometrial carcinoma, and that is underway in POTEC-4 trial. Even though I have mentioned a few of the trials that have been conducted on this topic, but there is a lot of studies that have been carried out on this topic. This table shows a list of those studies. The list continues in this table, and it is clear that there is a lot of work that has been carried out on this topic. The discussion will be mainly based on the following guidelines. In 2015, the European Societies of Medical Oncologists, Gynecological Oncologists, and Radiation Oncologists set a consensus conference on endometrial cancer, and they published their guidelines in 2016. 5 years later, that was recently in 2020, they formulated new guidelines, which they published first online on the 18th of December 2020. These new guidelines tabulate the risk group definitions, including the molecular profiles and the recommended adjuvant treatment in endometrial carcinoma. This table shows the definition of prognostic risk groups, and the groups are divided into low, intermediate, high, and advanced metastatic. And these groups are divided into two subdivisions depending on the known molecular profiles. So if the molecular classification is unknown, the low risk includes stage 1A endometrioid with low grade and focal or negative lymphovascular space invasion. If you have a look here, there is no risk factor noted. In the intermediate group, the stage 1B endometrioid has a low grade or focal or negative lymphovascular space invasion. The only one risk factor noted is stage 1B, which is 50% or more of the myometrial invasion. Next is stage 1A endometrioid with a high grade and focal or negative lymphovascular space invasion. The risk factor noted here is the high grade. The next is the stage 1A, the non-endometrioid, which are the type 2 endometrial carcinomas, which includes the serous, clear cell, undifferentiated carcinomas, or carcinosarcomas, or mixed. And these have no myometrial invasion. So this happens in situations where there is endometrial polyp, which is invaded by the tumor, but has 0% myometrial invasion. The high intermediate group includes stage 1A endometrioid with substantial lymphovascular space invasion, regardless of the grade and depth of invasion. So the substantial lymphovascular space invasion is significant. Next is the stage 1B endometrioid with high grade, regardless of the LVSI status. So both risk factors are noted, which is 1B stage and the high grade. And lastly, stage 2 tumors. And the high grade group includes the stage 3 to 4A with no residual disease of the endometrioid endometrial carcinoma, which is type 1 endometrial carcinoma, or the stage 1 to 4A of the non-endometrioid, which are type 2 endometrial carcinomas, and these have a positive myometrial invasion but with no residual disease. And lastly, it is the advanced metastatic disease, which is stage 3 to 4A with residual disease, or stage 4B. When we look at the molecular classification, there is 4 molecular markers which are noted, and that is polymerase mutant, the mismatch repair deficient, the non-specific molecular profile, and the p53 abnormalities. So these 4 molecular markers, the polymerase mutant, there is a data that is evident that this is a less aggressive tumors, and when they are positive, then stage 1 or 2, they are both low risks. And the second marker, which is p53 abnormality, this is an aggressive tumor, and this will automatically upgroup the tumor into the high risk group. In this intermediate group is involved when there is no myometrial invasion, that is the involvement of the endometrial polyp as mentioned earlier. Nonetheless, they are all following the risk group annotated. The recommended treatment is as follows. The low risk group, no adjuvant treatment is recommended. Intermediate group, the vaginal brachytherapy is recommended to decrease the vaginal recurrence. And in patients who are younger than 60 years of age, omission of treatment is optional, and that is level 3 evidence. The high intermediate group, the vaginal brachytherapy is recommended in patients who have a known nodal status and being negative. However, if the pelvic nodal status is unknown, the external beam radiotherapy is recommended. And if the cervix is involved, an additional vaginal brachytherapy will be recommended. In high risk group, the sequential chemoradiotherapy is recommended, and as per POTEC3 investigating team, the initial 4 cycles of carbotaxol is instituted first, followed by the pelvic external beam radiation. In advanced metastatic group, the multidisciplinary team or tumor board discussion is recommended, and in most cases, the chemoradiation in the form of palliation is offered. In conclusion, the endometrial carcinoma has many biological different tumor types, and this makes it challenging to adopt a single or common adjuvant treatment. The current practice remains primary surgery in the form of total hysterectomy plus bilateral salpingo-oophorectomy, then followed by the adjuvant treatment either in the form of radiotherapy alone, or chemoradiotherapy, or chemotherapy alone. Mainly this is guided by the histopathologic parameters. Genomic prognosticators are currently investigated to reduce overtreatment or undertreatment. The molecular profiles are currently a center of attraction for the etiology and the prognostication of endometrial carcinoma, as in POTEC4. Advanced disease is currently incurable. Chemotherapy is the mainstay of treatment in this situation. New directions of adjuvant treatment modalities are facing at the light of the anti-angiogenic therapy, the PEP inhibitor, and immunotherapy. Adjuvant treatment in endometrial cancer is currently undergoing active research phases, and this makes it a long way to achieve a common global practice. And on that note, I thank you. On that note, I thank you.